Welcome to the Wellness Exchange. October is Breast Cancer Awareness Month, so for this episode of the Wellness Exchange, we sat down with Dr. Chapa from DHR Health. She is a breast oncology surgeon, and we discussed breast cancer prevention and detection. We hope you enjoyed today's video. If you haven't already, please make sure to like this video and subscribe to our YouTube channel. Thank you so much for joining us, Dr. Chapa.
Thank you for having me.
Awesome. So we're going to get started. Is breast cancer a disease that really anyone can get, or is it more so determined by genetics?
That's a really great question, and one that we're still trying to figure out. So if the question is it a disease that anyone can get? Yes. So actually, some people think that only women can get breast cancer, and that's not true. Men also can get breast cancer. So we know that it's much more common in women. So 1 in 8 women will get breast cancer in their lifetime. So unfortunately, that's a pretty high number, but that's our average. That's why we all know somebody who's had breast cancer, because it's that common for women. In men, that average is 1 in 800. Oh, wow. Okay, so while it's much, much less common, it's still possible. But breast cancer is a disease of usually women that are postmenopausal, right? So women that have already gone through menopause. So the average age or the median age that someone would get breast cancer is like mid-60s. So we do see it more in that population, but I've seen it in women as young as in their 20s. And so the question about, is it, can anybody get it, or is it more prone to genetics? Anyone can get it, but there are some genetic mutations that do make you more prone to breast cancer than the general population. But what we know is that of all breast cancers caused by genetic mutations only make up 10% of all breast cancers. Oh, wow. So 90% of breast cancers, we still don't have a known cause. It's very likely multifactorial.
Wow, interesting. Good to know that.
Yeah.
So like you said, it kind of ranges in numbers, but you do have that kind of larger population that's postmenopausal.
Right.
Would there be a certain age, and I know that this is also something that's new, this genetic kind of testing that's coming into play, but it's an amazing,
incredible
resource,
tool. Yeah.
Yes, that we have now. What age would you say someone should maybe consider getting that genetic testing, or is there other factors that might play into getting it?
Yeah, so it's not necessarily age. There are a lot of other factors. So not everyone that I see do I recommend get genetic testing. Because when I say that I see patients who have breast cancer in my clinic, and that's what I do. I'm a breast cancer surgeon. But I also see a lot of patients that don't have breast cancer but have any type of breast complaint or have lots of family members. So it's not necessarily about at what age do you get genetic testing, but it's about do you have risk factors that put up red flags for us and make us concerned maybe you do have a genetic mutation. So this is where it's really important to talk with your family about your family history, right? So this is a conversation that everyone should go home and have if you haven't had it already. So talk with your parents, talk with your tias, your tios, your primas. What cancers have been in the family? So not just what types of cancers, but at what age were they occurring? So if you go home and you talk with your family and you realize, wow, there's a lot of breast cancer, there's ovarian cancer, and it's happening really young, and it's not just one person, it's my grandmother and her sister and my cousin. Then we start to see a lot of breast cancer in the family, and then we start worrying, could it be caused by a mutation in your DNA that's getting passed down through the generations? But if you go and you talk with your family and nobody in the family's had breast cancer, nobody's had any of that, then I wouldn't recommend genetic testing for you. So knowing your family history is really important in seeing patterns that would be concerning us for a genetic mutation.
So how would someone maybe know if they are, and I know you said about the family members and everything, are there any kind of other factors that would relate to like a high or low risk for developing breast cancer? Yeah,
so there are lots of things that make a woman high risk for having breast cancer. So we know, again, we talked about family history, and we do know that there are certain things that are just a part of the variation in a woman's life and her experiences that also increase risk of breast cancer. So we have lots of tools at our disposal. There's lots of different kinds. They're risk calculators. And so they generally ask questions about, at what age did you start menarche, which is your first, menstrual cycle? At what age did you have menopause? Did you breastfeed? How many children did you have? How old were you with your first child? All of this is getting inputted into a risk calculator that you can find yourself if you just Google Gale score for breast cancer.
Okay.
It's very simple. I do it all the time in clinic. I just pull out my phone. It's maybe 5-10 questions, yes or no questions, and it will give you your lifetime risk of having breast cancer.
Wow.
Right, it's really cool. So it'll give you your 5-year risk and then your lifetime risk. And it's not just the Gale score. There are Tyrer-Cuzick, there's Klaus, there's BRCA-Pro, there's lots of different kinds of models. But what it's trying to get at is overall estrogen exposure in your lifetime. So the more estrogen you've been exposed to in your lifetime, so the younger that you start menarche, the older that you experience menopause, you get more estrogen exposure, right? We know that that increases lifetime risk. So some women, just because, and you don't have anything, you can't affect when you start or stop menopause, right? But just because of, those factors, they can have more estrogen exposure, which increases their lifetime risk. And so what then happens is that we know that the average risk of getting breast cancer in a woman's lifetime is 12 to 13%, right? But if you plug your numbers in and you find out that your lifetime risk is greater than 20%, we know now that you're higher risk than average for getting breast cancer. It's no longer 1 in 8 women, you're 1 in 5.
Oh, wow.
So now we have to be way more vigilant about getting your mammograms, right? So we say the average risk woman should get mammograms starting at 40. But if you're high risk because just of your estrogen exposures, or you're high risk because maybe you had a biopsy that wasn't cancer but it had atypical cells, we should not only screen you with mammograms once a year, but we should also include some type of supplemental imaging like an MRI or an ultrasound in addition to the mammogram, and you should be getting breast exams every 6 months.
Okay.
So there are ways to figure out if you're high risk or lower risk, and then we need to modify the way that we screen you if you're high risk. So at DHR Health, our breast center of excellence I've been working for the last few years trying to build a high risk clinic, because I see here, especially in Hidalgo County, that we have a very, very large population of women with tons of family history of breast cancer, but then I do genetic testing and we don't find a mutation.
Wow.
But their family history is still there. So we know that they're high risk even though we don't have a genetic mutation. So we don't want to ignore those women. They're at a much higher risk of getting breast cancer. So we've started a high risk clinic where if you identify yourself as high risk through a genetic mutation, or high risk because one of these risk calculator models tells you that your lifetime risk is greater than 20%, or you're high risk through some type of atypia on a biopsy, you can enroll in this clinic, and it's specifically geared for women that are high risk, because screening saves lives. And so we want to monitor you a lot more closely, because what we do know is breast cancer is very treatable and curable if we catch it on time, right? If we can catch it on time, we can treat you fairly easily and cure you, but we have to catch it on time. So if you're higher risk, we monitor you more closely.
That's amazing. What a wealth of information, really. That's awesome. How do you spell Gale?
Gail.
Gail. We'll definitely leave that link
in
the description of the video.
I think it's so important.
That's an amazing resource as well. So how would you describe, maybe, are there some ways to reduce the risk via some lifestyle factors?
Yes, there aren't a lot, but there are some that we do know of that data and literature supports. So we do know that limiting alcohol intake to 1 drink per day at the most can lower risk of breast cancer. We do know that maintaining a healthy weight can lower risk, and also just exercise. So about 150 minutes of exercise a week. So I kind of break that up into 30 minutes 5 days a week.
Okay.
And the thought process there, at least for the healthy weight and the diet and exercise, that more contributes to keeping the healthy weight, is that we talked about estrogen exposure being something that increases breast cancer risk throughout our lifetimes. So our ovaries produce estrogen, yes. But another way that our bodies produce estrogen is through our fat cells.
Oh, wow.
So our fat cells, through kind of the beauty of biochemistry, can convert some of the hormones and proteins in our body and changes them into estrogen.
Wow.
So the more fat cells that we have, the more estrogen conversion and estrogen production our body has. Wow. So if we can lower our weight and lower those fat cells, we are lowering the estrogen production. I can't change the estrogen that my ovaries are producing, but I can lower the fat content in my body as much as possible to lower that type of estrogen production.
Wow, that is so interesting. I never knew that.
Yeah.
That's crazy. How very cool. Awesome. So now we've kind of discussed, some of the risk factors, the lifestyle factors. We can kind of move over into, I guess, like the different types. Are there different types of breast cancer? I know you mentioned that there was like a few different risk factors for them, and age or genetics plays a role, and lifestyle factors play a role. But does that also play into the fact that there are different types, and are they different among men and women?
So there are different types of breast cancer, and it really, really can impact the way that we treat, right? So, and this is what I tell a lot of patients that come in to see me with a diagnosis of breast cancer, and they want to automatically talk with their friends, as they should, right? Friends and family that they know have gone through this process before. But then they automatically, well, my friend didn't get radiation. Why am I getting radiation? Or I didn't get chemo. Why did she get chemo? Because there are lots of different kinds of breast cancer. There are lots of different types. There's invasive ductal breast cancer, which is 80% of all breast cancers are invasive ductal. So that's the most common type. But there's papillary, there's lobular, there's DCIS, there's lots of different types. But even more importantly, what we've really learned in the last few decades is that it's not even about the origin of the cancer cell, but the biology of the cell itself. So every cancer we look at 4 different, we call it immunohistochemistry, but I call them tumor markers. It's a lot easier to say. And we look at hormone receptor positivity, we look at the HER2 receptor, and we look at the Ki67. And so you can have any variation in these numbers. And so depending on, are you triple negative or are you HER2 positive? And it gets really kind of detailed, but that changes the way that we treat a lot of breast cancer. So some women with certain biomarkers, they're going to need chemotherapy first. Other women, they don't have those biomarkers, so they're going to surgery first, or they may never even need chemotherapy. So breast cancer, and I think this is the beauty of awareness, which like we're doing now, and the beauty of research, and just the beauty of like an entire population rallying around our loved ones and pitching in and donating to research, is that the more that something is researched, the more nuanced that the literature gets. And so we can really tailor treatment specifically to each individual person and each individual cancer, which is light years from where we were just 30 years ago. And so there are lots of different cancers, and there are now lots of different ways to treat it, lots of incredible medications. And so it's easy to kind of talk to a friend and be like, wait a minute, am I getting the right treatment because it's different than yours? But I don't want women to kind of be concerned if their treatment doesn't look like their neighbors or their mothers or their friends, because at this point it's a good thing. It means that we know a lot more about your cancer specifically, and we can tailor it to you specifically.
Wow, super interesting. That's awesome. I'm just so excited because of all this information. That's super cool.
Yeah.
Would you say, are there certain, or what I guess are the symptoms that someone would notice, or what would be the best way to detect if you might be suspicious of someone having cancer? And would you say that most of the time people are kind of figuring it out, or do you kind of find out earlier during screening options?
So I think there are 2 answers to your question. Okay. So how do people find out, or what are the signs and symptoms? So I think it's really important once a month that women do self-breast exams. So you would just stand in front of a mirror. I would say you can stand in front of a mirror and look at your breast, look for symmetry. Now, every breast is asymmetrical, right? So if you have always had one breast larger than the other, join the club. All of us are that way, right? And as long as it's your normal, that's okay. But it's more of a change, right? So all of a sudden, one breast has a different shape than it's had before, or it looks redder than it has, or maybe now you're noticing dimpling of the skin, or that the nipple is inverting or puckering in when it didn't before. So that's just the visual inspection. And then you need to do a physical exam, a physical palpation. So I'll kind of demonstrate here. What you would do is you would just put one hand behind your head to kind of expose this whole area, and then with the finger pads of your opposite hand, you can just go in circular motions around the breast, or you can go up and down, as long as you get the whole area, and feel for any lumps and bumps. Now, women have lumpy, bumpy breasts. It's natural. But this is why it's important to do it very consistently once a month, because you need to get to know your breasts and your lumps and bumps, so that maybe if you ever feel a new one, you can say, wait a minute, this is not part of the normal lump and bump. I haven't felt this one before. And if that happens, then you need to go talk with your doctor, to your PCP, and they will do an exam, and they're going to order a mammogram and an ultrasound to really work that up. So that's one way to detect. But another way to detect, and this is the way that we prefer, is that we find it on a mammogram before you can even feel it, right? So that's the beauty of mammograms, and that's how mammograms save lives. Because if you're waiting until you can feel the change, if you're waiting until you can see the change, it's probably a bigger cancer at that point, right? So we've kind of waited too long. We don't want you to get to the point where you can see or feel it. Now, of course, please still do the exam, but this is where mammograms come in. Mammograms are going to find cancers before you can even feel them, before they're even really large. And if we find that on time, we're going to find it very early. We can treat and cure your breast cancer. So I would recommend mammograms once a year, starting at age 40.
Okay, awesome. Thank you so much. I know you just mentioned a PCP, but what is that the basic kind of doctor that somebody would see if they believe they're at risk?
Yeah, so it would be either your family medicine doctor, your internal medicine doctor, or your OBGYN. OBGYNs do a lot of breast health as well. So it doesn't really matter who orders it, as long as it gets ordered.
Okay, awesome. And I know we discussed a little bit of kind of the advancements of some new technologies. What are some of those advancements in breast cancer treatments that maybe have played, quite a large impact in the increase of, cured patients that we've kind of seen, like you said, in the last kind of 30 years?
Sure. So, I think I really touched on it already, in the sense that we've kind of always known about the hormone receptor positivity or negativity and the HER2, but our chemotherapy regimens are much, much better. And we've had chemotherapy for a while, but in the recent years, we've really come up with targeted monoclonal antibodies targeted toward breast cancers. So those are an added tool that we can throw in to the treatment plan that just tends to work really, really well. So an example, there are certain breast cancers that are more aggressive than others. So we talked about those tumor markers, estrogen receptors, progesterone receptors, and the HER2. The HER2, it comes back in a positive or a negative result. So if you are HER2 positive, that is a more aggressive cancer. And so I used to, at the beginning of my career and kind of understanding breast cancer, when I would see a woman that was HER2 positive, I'd be like, oh man, they're HER2 positive, it's an aggressive breast cancer. I would really feel sorry and sad for this patient to have an aggressive kind. Now that's flipped on its head. Now when they're HER2, I'm like, oh, thank goodness, right? And it's the aggressiveness is still there, but the targeted treatment we have for HER2 positive breast cancers is so good. That monoclonal antibody, it's called trastuzumab. And pertuzumab, we've got 2 now. Those monoclonal antibodies are so good at really targeting and killing those breast cancer cells that the HER2 positive breast cancers, although they have the more aggressive, or one of the more aggressive kinds, they also have the best responses to chemotherapy. So more often than not, they do chemotherapy first, and when they come to me for surgery, we still have to do surgery, but at surgery we find out that the cancer is completely gone. And that it was completely gone with the chemotherapy and the monoclonal antibody. And that's just something that we didn't have before. And just in 2021, the FDA approved a monoclonal antibody called pembrolizumab, which we've had forever. But it's the first time that it's been approved in the treatment of triple negative breast cancer.
Wow.
And so now we're seeing really incredible results with that. So I think monoclonal antibodies in breast cancer treatments are really changing the game and giving women a lot better chances of survival.
That's amazing.
It is amazing.
Super cool.
It is amazing.
So we're almost done here, but how can our spouses, loved ones really provide that support for, a loved one of theirs that is currently battling breast cancer?
That is one of the most important things, I think, right? Mm-hmm. Because when someone gets breast cancer, it's generally a woman. Mm-hmm. They don't go through it alone. Mm-hmm. They have family members that really rally around them and support them. And sometimes it's really difficult. It takes a toll to see your loved ones sick from chemotherapy. It takes a toll to see them kind of recovering from the surgical process. And so for the loved ones, one of the most important things, at DHR Health, at our Breast Center of Excellence, at our Advanced Care Center, we have support groups that aren't just for breast cancer patients, but also we invite and encourage their family members to come and participate, to learn about ways to do self-care and self-help, right? So one of the things I say is take care of yourself if you're a spouse or a family member. Really, you need to prioritize your mental health, your physical well-being, because you can't take care of your loved ones if you yourself are ill. And so that's some of the things that we talk about at our support groups, is really making sure that the entire support group is healthy and not just our breast cancer patient that we're treating.
Mm-hmm. Wow. Okay. Yeah, that's so true. Because you have the caregivers that just give and give, and then they end up, also
right. So
they need to take care of themselves.
You do, yeah. And so we try to do our best to pour into them as well.
Yeah, that's lovely. Love that. Do you have, before we kind of wrap up here, do you have any final words of wisdom, advice, guidance for our listeners in regards to breast cancer?
I do, and I say this all the time, and this is the message: get your annual mammograms. Mm-hmm. Do not skip it, because mammograms, they save lives. Like we talked about, it's going to find a cancer before you can even feel it, right? Don't wait. And like all the advancements that we talked about and all the tailored treatments, our treatments are so good. So the statistics now, and this is incredible, the statistics now is if we find breast cancer and it's stage 1, mm-hmm. that's the earliest stage we can find a breast cancer. Mm-hmm. Women who are stage 1, they have to go through the breast cancer treatments. They do. But we know that 95 to 98% of these women live entire full lives after their breast cancer treatment, never having to deal with breast cancer again. They live a full life. They become grandmothers and great-grandmothers, right? So that's how good breast cancer treatment is now in 2022. But we have to catch it on time. Right. And the best way for us to catch it on time, it's with an annual mammogram. Mm-hmm. So I know there's a lot of fear surrounding mammograms. It's going to hurt. I don't know what to expect. What if it finds it? But really, this is your best chance at saving your life. So get your annual mammograms.
Awesome. Thank you so much. Well, yes, thank you so much for joining us today for the Wellness Exchange, Dr. Chapa. We really, really appreciated all this wonderful information. To our audience, if you haven't already, please make sure to like and subscribe this episode of the Wellness Exchange, and we will see you next time. Thank you so much.
Welcome.